Well, thank you again. So I may vary my presentation from the slides that you're going to see in order to make some important points as I go along with this presentation. So bear with me here. So I want to talk about quantitative risk assessment because it's beginning to emerge as an effective tool and approach to guide labeling, especially precautionary labeling, recall management by public health authorities, and the establishment of allergen control programs by food manufacturing companies. But it's not yet widely adopted by public health authorities or widely adopted within the food industry, even in North America and Europe. There are some noteworthy companies like Unilever that do it, but it's not widely adopted by most others. And as I've already pointed out, and Renee emphasized as well, we have really good data on threshold doses for human consumers with various food allergies. We also have, I would say, reliable analytical data if it's expertly evaluated and viewed with some caution. I think a lot of users of the analytical data don't recognize how hard it is to evaluate whether the analytical method is fit for purpose. Renee just mentioned that the analytical results should be calibrated in terms of parts per million of protein from the allergenic source. So parts per million milk protein could be my example. In fact, if you go to the marketplace and look for analytical methods for milk, very few of them will be calibrated in terms of parts per million total milk protein. Instead, they will be calibrated in various terms: parts per million non-fat dry milk, parts per million casein, parts per million lactoglobulin. And how many here know that 1 part per million beta-lactoglobulin is equal to 28.6 parts per million of non-fat dry milk? You can go home and make that calculation, and you need to do that even to figure out which test is the most sensitive. You may have a kit salesman who tells you, our test is the most sensitive because it detects down to 0.1 part per million of beta-lactoglobulin. That's not the most sensitive test on the market. Just sounds like it. Reliable consumer information is necessary for risk assessment as well, and I don't know the extent to which Brazil has information on what food consumers eat in Brazil. We have great data in the United States. Some European countries have really good data, but many others do not. And these three elements form the basis for quantitative risk assessment. And Renee mentioned this European framework funded project. We are involved in that, even though we're from the United States. We're the only non-European partner in this project. It's called IFAM, which stands for Integrated Food Allergy and Food Allergen Management, and it's a Framework 7 project. There are 32 partners involved in 10 work packages on various aspects. It's a 4-year project that's scheduled for completion early next year. There is a risk assessment aspect for the food industry within one of these packages. It is specifically Work Package 5, so it probably would not surprise you that Unilever is involved and FARP is involved in this project. Our other partners are TNO, which is the research consulting organization in the Netherlands, the Danish Technical University in Denmark, ANSYS in France, and Hylobates, which I didn't know about them until this project started, but they're a risk assessment, risk management consulting company in Italy. And so in terms of Work Package 5, our objective was to develop a validated tiered risk assessment and evidence-based risk management approach for food allergens in the food chain. So if we're going to do what Renee suggested, we need to have a straightforward approach that food companies can use. And when this is released, that approach will exist. It hasn't been released yet. Look for it early next year. But here's what it will be. There will be a Tier 1 risk assessment, which it can be very simply described. It's a process to estimate the possible risk of unintended allergen presence. So you determine if obviously if the exposure dose to the product is below or at some certain risk level, the reference dose, then you don't need to be concerned. You don't need to label. You don't need to put a precautionary label. But if the exposure dose is above that reference dose, then your first step should be to take risk mitigation steps to go back to step 1 of the risk assessment and hopefully now fall into that category. Or you can also decide to label at this point right here, or you can go to a more sophisticated Tier 2 risk assessment to determine more precisely what the risk of allergic reactions would be within the community. So we will be producing what we call the allergen tracking tool. It is used to determine the likelihood that cross-contact with an allergen will occur in manufacturing processes and that allergen will appear in the consumer process. So again, you determine whether cross-contact can occur, and if so, at what level. You do this by analyses. And then you look at how much of that product the consumer might eat. And if the exposure dose is above the reference dose, then you can determine whether you have a risk or not. If you have no risk, then you don't need to label. Your allergen control program is fine. You proceed happily along. If you do the hazard assessment part and you find that there's no risk of cross-contact, then obviously right at the very beginning you have no action necessary. But if the exposure is above the reference dose, then you can do these risk mitigation measures to take you back here, or you can do this more complicated analysis. So the allergen tracking tool will involve the identification of the unintended presence of allergens. You do an in-depth process of vulnerability assessment in an allergen mapping exercise of looking where the allergen might go in your manufacturing facility. It's somewhat similar to the guide that I heard about this morning, except that it identifies that certain risks are going to be much higher than others by definition. If you make 2 products on a shared piece of equipment that's very difficult to clean, then you understand in your vulnerability assessment that you're going to have likelihood of a higher risk. Dust was mentioned this morning. Dust migration in almost every circumstance leads to such a low risk that nothing needs to be done with respect to dust. But so you take these issues. I didn't steal the pictures here to bring to you today, but we have these action measures that can be taken. So you have various ways in which an allergen can enter a facility, And I'm talking about unintended allergens, not intended ones. But it can be an ingredient in some recipes in the facility. That means that shared equipment or even practices within the facility can lead to cross-contact. But if it's already an ingredient in all of the recipes, then all you have to do is ensure that appropriate contains labeling is applied and you're done. So an example would be a bread bakery. If wheat is in all of the formulas and you put wheat on the ingredient statement for that product, you're finished. But in that same bread bakery, you might have milk as an ingredient in several bread recipes, but not all of them. Then you have the possibility of cross-contact. You can also have unintended allergen present in an ingredient. So you could have soybean residues in your wheat flour because of commodity commingling clear back on the farm, or in grain elevators, or rail cars. And how consistent in that? What level do you find? How much do you dilute it in the recipe? Well, in bread baking, you don't dilute it very much because wheat flour is a big ingredient. These are supplier issues. Sometimes they can be controlled, sometimes they cannot. So the Tier 1 risk assessment is going to be a really simple online tool that I think every manufacturer in this room will have the capability to do on their own with no expert assistance. That's the plan anyway. And it requires minimal input from users. It's going to be fast. It's going to be on various websites. It's going to lead to a binary yes-no approach. Your inputs will be analytical concentrations of the allergen of interest. And you want these in parts per million of protein from the allergenic source, or you're going to have to convert them if you use a method that doesn't provide that. The consumption level estimates, you can use the serving size, but if you have more in-depth data in Brazil about what consumers eat, you know that there's a lot of consumers that are big guys like me, and they don't usually stop at one serving. So they might eat more sometimes. And if these two levels multiplied together are green, then the product's going to be safe. If they're red, then you have a potential unsafe situation that can lead to precautionary labeling, to a Tier 2 risk assessment, or towards some risk mitigation strategy that you might employ to try and get over towards green. So risk is just the contamination level times the consumption level. But you need to start with a reference dose. So if the authorities in Brazil don't allow the establishment of a reference dose, then I think industry has to do it themselves. So the authorities may be reluctant to establish reference doses, but companies have to do it in order to figure out how to control their allergen risk. So you have to have a corporate target level. Maybe you can do what the Australians did and collectively decide what that should be for all companies in Brazil. You could use a simple exposure estimate such as the serving size. And as I said, if the exposure level exceeds the reference dose, then you have a hazardous situation. Recognize that the degree of hazard is depending on the assumptions used to calculate the reference doses and the assumptions made about consumption levels. But I want to point out that the actions are not always labeling or precautionary labeling. And the establishment of reference doses is not just to control precautionary allergen labeling. The most important action should be risk mitigation steps, because then you don't need the precautionary allergen labeling. Good manufacturing practice would say, if you can economically reduce the risk, then you must. So please proceed. It also helps with authority decisions about source labeling exemptions of specific ingredients. As I mentioned in the question session this morning, authority decisions about the acceptability of commodity commingling. That's going to be important because it's really going to be difficult to control, and decisions about the need for recalls. So we have a path towards reference doses that I described this morning. We have these clinical oral challenges that establish thresholds for each individual consumer, and then we can use the distribution of individual threshold doses to establish population threshold distributions. And from that population distribution, we can predict the percentage of allergic consumers who would be predicted to react to any specific dose of the allergenic food, and we can use those population threshold distributions to establish reference doses. We know that trace amounts of the offending food can elicit reactions, but it's not zero, and severe reactions do not occur at low doses. In that one-shot study, that single-dose study for peanuts that Renee mentioned that was done at the ED5, we found 8 reactions, but the most severe reaction was a single episode of vomiting that occurred in a child who immediately recovered and didn't have any other symptoms following that, and the appearance of several hives that disappeared within 10 minutes without pharmacological intervention. So I don't think either one of those are very severe reactions taken in context. So there are a lot of approaches that could be used to establish threshold doses. I've been focusing on the risk assessment method this morning, where you model the entire distribution using these statistical dose distribution models and select an acceptable risk level and use the dose that coincides with that as your reference dose. You can use other approaches, as the Japanese used an analytical approach, but this is certainly the most robust approach that you can use. It's the only approach that uses all of the available human data. It requires the most data to have statistical confidence, however, and the patients whose individual threshold doses are in the distribution must be representative of the whole population with allergies to that food, but I think we have achieved that. This approach is endorsed by the US FDA. They don't officially endorse it, but they use it. It's selected by the Europroval Consortium, which was 55 partner organizations throughout Europe. It was selected by ILSI Europe in a task force that René Crevel happened to lead, but he had to convince a lot of other expert participants that this was the good approach. And of course, it's been pioneered and used by the Allergen Bureau of Australia and New Zealand. FDA back in 2006 led us down this path. We didn't do this because we thought it was a good idea. We did it because they thought it was a good idea. And this is an 80-page report, and I only printed one paragraph, or part of one paragraph, and the red highlights are mine. The quantitative risk assessment-based approach provides the strongest, most transparent scientific analysis to establish thresholds for the major food allergens. But now this is 2006. The currently available data are not sufficient to meet the requirements of this approach. A research program should be initiated. So we did that to develop applicable risk assessment tools and to acquire and evaluate the clinical and epidemiological data. So now we can say, do we have enough data to use this approach? Yes, we do. And I'm going to skip some of these slides so that I can, you've seen some of these before. the dose distribution for peanut. I continue to use peanut as my example. I want to get you to an actual risk, quantitative risk assessment. And since I showed you these slides this morning, I do want to make the point that the reference dose for peanut that we chose for the Australian Allergy Bureau was the ED01, the dose that would be predicted to cause a mild objective response in the 1% most sensitive individuals in the peanut allergic population. But our single dose trial was done at the ED05, because in order to do the ED01, statistics tells you that you got to have like 3,000 patients. That's going to take a lot of time, cost a lot of money. With the ED05, you could do it with 375 patients. So pragmatically and in the interest of financial viability, we did the ED05. So the ones in green, I failed to mention this morning, we had more than 200 data points, so we could statistically thought that we were okay to use the ED01 as our basis for the reference doses. But that was kind of an arbitrary decision. A public health authority could choose to use the ED05. Now, with the results emerging from the single-dose peanut experiment, I would say that using the ED05 it would be a perfectly acceptable decision. For these in yellow, we didn't have enough data points to statistically, we had less than 100 in every case. So figuring out the ED01, I'm not the world's greatest statistician, but figuring out the 1% dose when you have less than 100 subjects is glorified guesswork. And so we used the 95% lower confidence interval of the ED05, which would probably be the ED2 or 3. So you've seen all this before. So these 4 are the ED01. The rest of these are the 95% lower confidence intervals of the ED05. And they're in milligrams of protein from the source. Why did we do that? We did that because clinical investigators will use different forms of the food for these oral challenge studies, and we wanted to use their data, but we had no control over what they had already done. So they might have used peanut butter or crushed whole peanuts or peanut flour, so we had to somehow normalize the data. The easiest way to do that was to convert it into milligrams of protein from the allergenic source. So now we need analytical data that matches up to this so that you don't have to figure out what the conversion factors are in order to match them up. So in the safety assessment, the Tier 1 risk assessment is really sort of a deterministic approach and can lead to the Tier 2 risk assessment, which is, I'm going to talk about more, is actually a probabilistic approach. That approach, individual users are probably not going to be able to do because of lack of access to the threshold data set, which belongs to TNO and FARP. So you're going to have to come to us, but many of the companies in this room are members of the Food Allergy Research and Resource Program Industry Consortium, so you get to come to us at no charge to help you with this, because your companies have already paid in. So we have the reference dose for Tier 1, we have the reference dose, we have the serving size or some other estimate of consumption, we have the allergen concentration, and we do a simple math calculation. But here, for the tier 2, we need all of the available data from the individual patient thresholds, from the food challenges, all of the consumption information that we can get, again, the allergen concentration, and we have to use advanced statistics. So this requires expert assistance in judgment. This is going to be on the IFAM website as well, but you're going to be directed to the experts who can help you with this. Of course, the decisions are going to depend on the risk tolerance of the user. So if I tell you there's an allergic consumer is going to have a reaction, what are you going to do? That's your decision, not mine. But that's the level of risk management that would happen here. This approach requires a lot more information. It requires, as I said, the concentration level, the consumption, ideally from national surveys. You could use the US survey. We've done that when doing risk assessments in Mexico. They don't have a national survey of consumption patterns of Mexican consumers. So we made the assumption that Mexican consumers eat like US consumers. That's probably not true, but it's probably not way off in many cases. There may be some foods where it is way off. And someone mentioned regional foods this morning. That would be one example where I might choose to use serving sizes instead. And the threshold dose distribution. So again, quantitative risk assessment is emerging as an approach. Let me show you how that works. So here it is in pictorial form, thanks to my friends at T&O. We've talked about the threshold dose response curves. And we have this threshold dose distribution data. And if you plot it in this manner, you're going to get a Gaussian distribution, and the most sensitive of the consumers are down here, and the ones that can eat a handful of peanuts before their reaction are out here. You can also use as an input the prevalence of the allergy within the population. Now, in the United States, we know that about 0.8% of Americans have peanut allergy. I have no idea what the number is in Brazil. You probably don't either. You don't have to use this as a variable, but you could. And you also need other information. So in the United States, we use this National Health and Nutrition Examination Survey done by our U.S. Department of Agriculture every several years that measures what Americans eat and how much of it they eat. So this gives us the probability that any given consumer will eat a certain food that might be under question in the amount of that food that they would consume. And from that, you can find out what the average consumer eats of that food and how often. You can find the 90th percentile consumer, the 95th percentile consumer, and if you want to be really conservative, the 99th percentile consumer. But I don't like to use 99th percentile consumer because I think you're getting into the outliers in the data set then. For example, I looked up tomato ketchup just for fun one day, and the 99th percentile consumer of tomato ketchup in the United States eats 495 grams of ketchup a day. That's a lot. That's a pound of ketchup. And there may be somebody that actually does that, but it would be a bizarre eating habit, I think. You also need the product analytical information. So how much of the allergen do you find using allergen methods? And if you may have multiple data points, so you can have the probability that you're going to find detectable allergen. You multiply those two things together, these two distributions together, you get the allergen intake distribution. And again, it's where the most highly contaminated product intersects with the most sensitive consumers where you have a risk of an allergic reaction. So we have really great threshold dose distributions, especially for peanut, milk, egg, hazelnut, and as of 2016, cashew. We have food consumption estimates, really great for the US. I don't know about Brazil. Analytical estimates of allergen residues. I'd like to promote ELISA methods because they measure allergens from the source food very specifically. They're appropriately sensitive down to part per million levels. They don't need to be any more sensitive than that. But note that they're often not validated with naturally incurred standards. In fact, many of them are not validated at all. If you can find an AOAC validated method, great, use it, because that's going to be better than nothing, even though that's not validated with what I call naturally incurred standards, where you deliberately put the peanut or other allergen into the food and then take it through a baking oven or something and then try to extract the protein so that you include the effect of processing on the ability to extract the allergens. And I already mentioned that methods can have variable calibrators with questionable adjustment factors sometimes. So these points, these methods are the approach moving forward, but we're just learning how to effectively use these. Allergic consumers worry about the safety of reference doses, but I think we just need to convince them or educate them more about what it is we're doing in a way that they understand it. If I give them the full statistics talk, their eyes glaze over and they don't understand. And basically, sometimes I don't either. The public health authorities are very cautious about the definition of the acceptable level of risk and the establishment of reference doses. So again, I would encourage food companies to do this themselves. You have to have a corporate target level in order to use what we're talking about today. The food industry has been slow to adopt quantitative risk assessment because they don't know that the authorities will accept those analyses. And analytical methods have become a key source of concern as well. So reference doses are the only path forward, but we've got to help consumers understand what we're doing. We have to convince public health authorities to use the reference dose concept and industry as well. And analytical methods companies could really do a better job than they're currently doing about leveling the playing field. Some of the variability is intentional to try to get commercial advantage in selling their kits over others. So let me show you an example. I wanted to quickly go through the other slides so that I had a chance to do this. In late 2014, close to Christmas holidays, I love it when it happens at that time of year, and into early 2015, a number of recalls occurred in the United States due to the probable adulteration of cumin spice with peanut. Somebody, in my view, deliberately put it in there, and it caused very high levels to be present in foods made with cumin, and consumers got sick, and FDA had to take action, and the companies involved had to take action, and there was really no disagreement in any sector about that. But after the initial series of recalls involving this adulterated cumin, many companies understandably begin to test for peanut residue in cumin and other spices. Well, lo and behold, they found random low-level positives between 5 and 25 part per million in whole cumin seed with no visible signs of whole or parts of peanuts. And this was likely due to incidental cross-contact due to agricultural commingling. I do not have definitive evidence of that, but cumin comes primarily from India. 90% of the world's cumin comes from India, and the farmers in that region of India also grow peanuts. And I think they could be responsible for the commingling. How do you educate those individuals? I think it would be very challenging. But are these low-level agricultural commingling results a public health risk? Well, we did a quantitative risk assessment to figure that out using this strategy. So we decided, tacos, you know what those are, I assume? Yes? Okay. Very popular product in the United States. Cumin is a hot spice, so taco seasoning almost always contains cumin. So we assumed, for the purposes of this exercise, that the level of peanut in the cumin was either 10 or 25 parts per million, because that was in the range that we found in some of these samples. This seasoning blend contained 8.4% cumin. This is actually somebody's product, but I won't tell you who. But that's within the range of other companies. So the parts per million in the seasoning blend drops because you only have 8.4% cumin in the seasoning blend. The percent seasoning blend in the taco meat it goes down, it's 6.2%. So the parts per million peanut in the taco meat is below the level at which you could measure it with any commercial assay that I know of, but you can calculate it. And then the proportion of the total taco meal, the taco meat's 35%, the tortilla's 45%, there's usually lettuce and tomatoes and cheese. You get down to really low results. Then you go to the consumption side. Well, I think there's about 13,000 consumers in this database, but 1,526% of them reported eating tacos on one of the 2 or 3 days that they were evaluated in this survey. That's 4.6% of the US population consume a taco on any given day. And the average amount that they consume would be probably about 1 taco, 208 grams. But then you've got your 90th percentile consumer, your 95th percentile consumer, and this guy out here that eats about 7. So that's, again, my point about using 99th percentile consumers. So what's the risk? So you take the concentration in the food product and you multiply it by the amount that's consumed, in this case, we took the whole distribution of consumption, and we determined that the user risk, this user risk assumes that all of the consumers are peanut allergic. So this would be the risk of the peanut allergic segment of the Brazilian population. 2.8 reactions per million peanut allergic individuals. For those of you who can't think in terms of reactions per million, it's, if I put it in percentages for you. Of course, at 25 parts per million, the risk goes up to 1.6 reactions per 100,000. But if we then determine that the peanut allergic, I made a mistake here. Let me go. The user risk is the risk that the peanut allergic consumer would actually buy and consume the taco. So it takes into account the likelihood that he would actually eat a taco on a given day. Now we assume that we look at this for the whole peanut allergic population, and because it's 0.8%, now we're down to 1.3 reactions per 10 million peanut allergic individuals 7.6 reactions per 10 million allergic individuals. And if we calculate it over the entire U.S. population, then we get down to really low numbers. So my conclusion would be that's not very risky. And then we did the same thing for chili, which is another popular product in the United States. And I won't go, chili is consumed in even larger amounts, about 2.4% of consumers, but the 99th percentile level of intake's really out there. And again, you see that the likelihood of reactions at 10 parts per million peanut and cumin or 25 parts per million peanut and cumin is really low in the overall population and even in the user risk group. So in our estimate, trace levels of peanut between the limit of quantitation and 25 parts per million in whole cumin used in finished products does not present public health risk based on what we know about the clinical thresholds in peanut allergic individuals. But we would also say the authorities have not established regulatory action levels for food allergens. But in the United States, they've just quit looking for peanuts and cumin, even though peanuts and cumin still exist from India, although the levels have dramatically dropped. We're finding 25 parts per million on a frequent basis. Now it's more likely 5 to 10. How did they do that? Well, the spice companies started giving these poor farmers in India, they don't make very much money, they started giving them fresh burlap bags. What they found out was that they were using the same burlap bags to take peanut meal from the peanut oil processing facility home to feed the cow, and cows are sacred in India, and then they were using those bags again to bring cumin back to the marketplace. So that's probably where a lot of the peanut contamination was arising. Thanks a lot.